binds the.
Yes. So why it won't?
Find out why it does not block the benzyl isoquine.
No, you know the mechanism of action of sugammadex, isn't it? Because yesterday we were discussing it has got an hydrophilic exterior and a hydrophobic interior.
Yes, sir.
The hydrophilic exterior actually binds to the quaternary ammonium portion of vecuronium and pipecuronium and rocuronium and all. And the steroid nucleus will enter into the hydrophobic interior. And that's how it binds. And the binding is very, very strong binding it produces. Whereas with the molecules of benzyl isoquinoline group of drugs, whether it is tracurium or cisatracurium, they are very large and they have got a long side chain. Because they are large and they have got a long side chain, so they cannot enter inside the hydrophobic interior of the sugammadex. Once it cannot enter inside the hydrophobic interior of the sugammadex, there can't be binding. So that is the reason why, benzyl isoquinones cannot be reversed by use of sugammadex. That's why sugammadex is called as a selective, relaxant binding agent. Now you have followed, isn't it? Because
Yes,
of
sir.
the largeness of the molecular size of, tracurium and cisatracurium. So the binding cannot occur. And even with, I was telling you that it binds very strongly with rocuronium compared to vecuronium. So vecuronium molecule, yesterday I was telling you that molecular weight of vecuronium is 632. Whereas the molecular weight of rocuronium is 500, roughly 502 or 504. So rocuronium molecule is slightly smaller than vecuronium molecule. That's how, vecuronium and sugammadex combination is effective, but not so effective when compared to the combination of rocuronium and sugammadex. That combination, that binding. That's why it rapidly binds to rocuronium compared to the binding with the vecuronium. It takes slightly more time to bind to the vecuronium molecule. That way, pipecuronium, it's more strongly bound because pipecuronium molecular weight is still less when compared to rocuronium. But we are not using pipecuronium because pipecuronium is a long-acting drug, long-acting aminosteroid, stopped using. But now with the advent of sugammadex, in US and in European countries, they have started again using pipecuronium because anytime it can be reversed, isn't it? Because of availability of sugammadex, pipecuronium they have started using because then the duration of action doesn't matter at all. Anytime you want to reverse, you just use sugammadex and pipecuronium or pancuronium for that matter. Even pancuronium can be reversed with sugammadex. But again, pancuronium is slightly larger molecule, so binding is slightly less. So pipecuronium being a smaller molecule, so binding can be more effective. So that's how, that is the reason you have to know the basics of how sugammadex will produce the reversal of rocuronium or vecuronium or any of these drugs. It is basically already yesterday we discussed it is a one-to-one binding. Yes. One molecule of sugammadex will bind to one molecule of rocuronium or vecuronium or pipecuronium or pancuronium. It is one-to-one. That's why I was discussing with you yesterday that because the molecular weight of sugammadex is 2002, it is almost 4 times the molecular size of vecuronium. So if you want to give one molecule of rocuronium and one molecule of sugammadex for binding, so sugammadex has to be given 4 times of rocuronium because sugammadex weighs 4 times heavier than rocuronium. That is why a minimal amount of drug, rocuronium, sugammadex, if you have to give after giving rocuronium, is 4 times that dose you have to give. So now you understood, isn't it? The minimal dose. That is why you don't give the same dose. Because, otherwise you would have thought, okay, one molecule, if they are of equal molecular weight, then you would have given the same dose of whatever you had given rocuronium of sugammadex. But you cannot, because sugammadex is 4 times heavier than rocuronium. So minimum 4 times the dose of rocuronium you have to give as sugammadex, if at all, if you want to reverse the effect of rocuronium. So that is a thing which you have to know about. So any other doubts you had regarding neostigmine also? Neostigmine and glycopyrrolate combination and sugammadex. Sugammadex anyway we are going to discuss today. So any other doubts you had regarding reversal with conventional methods?
So it's not about reversal, but generally neostigmine, when I was going through something, I just saw neostigmine can be given in epidural also. What is the purpose?
Yes.
That I was not able to
Yes.
figure it out. Analgesia and
Okay.
labor.
So good thing that you asked about this. This is nothing to do with the reversal of non-depolarizing muscle relaxants. I used to use neostigmine in the epidural.
Okay.
One advantage of using neostigmine in the epidural along as an adjuvant to local anesthetic. You don't use neostigmine alone.
Okay, sir.
Like we use local anesthetic with opioids, local anesthetics with alpha-2 agonists like clonidine, dexmedetomidine. Like that, you can use neostigmine in the epidural along with local anesthetics like either majority of the times usually bupivacaine, because the longer acting bupivacaine. So when you use neostigmine acts on the ganglia there, the sympathetic ganglia. So by in the sympathetic ganglia there, acetylcholine is the neurotransmitter. That
Yes,
you
sir.
should always know. All, whether it is sympathetic ganglia or parasympathetic ganglia, the neurotransmitter is acetylcholine. That's how some of our neuromuscular blocking agents will also act on the sympathetic ganglia and also produce hypotension, like D-tubercularine. It has got a ganglionic blocking properties. By blocking the acetylcholine at the or nicotinic receptors in the sympathetic ganglion, it produces peripheral vasodilatation, D-tubercularine I'm talking about. That's how it produces quite a bit of hypotension, which was used as a therapeutic benefit because you require some amount of decreased blood pressure during surgery so that the bleeding can be reduced. So that's how they were using D-tubercularine both for muscle relaxant effect and its hypotensive effect. That means, there are nicotinic acetylcholine that is will be released in the sympathetic ganglion that will be acting on the nicotinic receptors there. That's how, the peripherally what we have is the vasoconstriction normally, the preganglionic fibers. So there, by increase of acetylcholine in the preganglionic level by neostigmine, acetylcholine actually acts as an analgesic in the spinal cord. That you should always understand. Increased level of acetylcholine in the spinal cord will produce analgesic effect by acting on substantia gelatinosa. That is, you have various lamina in the posterior part of the spinal cord, dorsal horn of the spinal cord. So lamina 2 and lamina 5 are involved in pain transmission. So lamina 2 is otherwise called as substantia gelatinosa. So their increased release of acetylcholine can block the transmission of pain. So neostigmine, by acting there, when you give epidurally, so locally it produces increased availability of acetylcholine, and acetylcholine will help in decreasing the amount of pain. So that there is analgesic effect, and the local anesthetic along with neostigmine will produce a prolonged duration of analgesia. So that's how neostigmine was used. But one of the drawbacks of neostigmine when you use it, so because it releases acetylcholine, the preganglionic sympathetic fibers get activated, preganglionic neurons get activated. Once the preganglionic sympathetic neurons, they get activated because they have nicotinic receptors. Acetylcholine, increased level of acetylcholine released as a result of neostigmine will activate these neurons, and in turn, the postganglionic fibers, sympathetic fibers. So they release a lot of noradrenaline and produces vasoconstriction. That's how, when you use neostigmine, there is always a possibility of hypertension.
Okay.
The opposite would occur with DTC because it would block these neurons there, nicotinic, the receptors there by, blocking the effect of acetylcholine there. That is DTC. Now, because more acetylcholine now is available, so more of these neuronal activity increases, nicotinic receptor activation occurs. Postganglionic release of noradrenaline from the sympathetic postganglionic fibers occur. So noradrenaline will be acting on the smooth muscles alpha receptors and produces vasoconstriction. That's how there is a possibility of increase in the blood pressure. Second possibility is there will be a lot of sweating. The sweating is again because of the release of acetylcholine and the sweat glands by neostigmine. So you should think that sweat glands also are sympathetic ganglion they have, but their preganglionic fiber is long. Normally, in the sympathetic system, you have a short preganglionic fiber and postganglionic fiber is long.
Yes.
This is the exception is sweat glands. Sweat glands, the preganglionic fibers is long because the ganglia is present inside the sweat glands itself. And acetylcholine is a neurotransmitter there. That's why when you give atropine, there is blocking of the sweating, isn't it? So that is what occurs. There is, because this acetylcholine released in the sweat glands will stimulate and there will be a lot of sweating. So these two problems are the side effects of when neostigmine when you give epidural. So, but these effects can be reduced if you use the neostigmine less than 200 micrograms in the epidural space. So you have to use not more than 200 micrograms total. When you use along with, for example, if you're using, say, single bolus dose of epidural bupivacaine, if you're using about 10 ml or 15 ml, along with that, you can maximum you can use is 200 micrograms of, neostig. Otherwise, you are using 0.05 milligram per kg body weight of neostigmine for reversal, isn't it? Yesterday, we were discussing 20 to 50 micrograms per kg body weight, that is. Here, maximum you can use is 200 micrograms, mainly to decrease the increase in blood pressure and increase sweating that can occur. That's why, there were a lot of papers. Even I presented, published a paper. Combination of neostigmine and clonidine along with bupivacaine in the epidural space.
Okay, sir.
So, 75 micrograms of clonidine along with 200 micrograms of, neostigmine along with the 0.125% of bupivacaine. So this could produce prolonged analgesia, one advantage, because synergistic effect of clonidine along with neostigmine. They have different methods of action because clonidine acts on alpha-2 receptors in the spinal cord and produces analgesia. Neostigmine, by increasing the level of acetylcholine, so it produces analgesia. So, but the side effects, the clonidine side effect is hypotension. But the side effect of neostigmine is hypertension. So one-to-one, they get nullified. There won't be any hypertension or hypotension when you combine clonidine with neostigmine. Plus, there won't be any, because, clonidine is though it is adrenergic drug, it produces agonistic activity, the alpha-2, but actually it decreases the release of norepinephrine at the peripheral nerve ending. And also by blocking stimulating alpha-2 receptors. So that's how, though neostigmine tries to increase the noradrenaline release, clonidine will decrease the noradrenaline release peripherally. So good effect of, normotension will be maintained and there won't be any sweating with neostigmine. So that's how, a combination of neostigmine with clonidine. So actually I used it for many patients. I used it and quite effective. But somehow, people are not using nowadays. I also used to use it almost 10 years back, somehow because we have better drugs now available. So we started using opioids or alpha-2 agonists alone in the epidural space. So morphine is available, fentanyl is easily available, buprenorphine is available. So they are quite good. So why try neostigmine, clonidine combination and all? Now I hope you have understood how neostigmine will
Works.
act as an analgesic at the spinal level.
Yes,
When,
sir. Yes.
but you should not use more than 200 micrograms.
200 mg. Yes, sir.
Maximum. That is the maximum you can use. Okay, good one. Doubt you got it clear. That means it shows that you were reading yesterday about.
Yes, sir.
That is a healthy thing to know about. Very good.
Thank you.
Any other doubts regarding these reversal agents? Anybody else had any doubts? They can even now also they can just put a message in the chat box if they have any doubt, so that we can clear that and then we can go ahead with Sugammadex. We're discussing about Sugammadex is one of the most commonly asked short notes in your advanced paper 4 or even paper 1. I still remember in 2007, I think I had gone to Kerala as an examiner. So one of the theory questions was the short notes on Sugammadex. So we had about 12 students or 13 postgraduates attending that. And we used to correct the question papers, the answer papers of those students only during those days before exams. So I was correcting and none of these, out of 14 or 15, none of the students had attempted the question because it was absolutely new then. Sugammadex, nobody had heard about Sugammadex. It was just introduced and it was only introduced probably in some Australia and European countries, 2007, 2008. So students had not heard about it. So only one student had written that it is a newly introduced neuromuscular blocking agent. And he had written, just like that. Because he must have heard about Sugammadex and neuromuscular blocking agent. So he thought that it is a new neuromuscular blocking agent. Actually, it is a reversal agent. So what I
Yes.
gave him 2 or 3 marks. And he required about, for 50, he required about 2 or 3 marks. I gave 3 marks for whatever at least he has attended. That's why I want to tell you people that when you don't know anything also, you have to write something. At least you know some related, part of the question as far as you would have read. And even if you don't know much, do not leave any question unattended. Every question you should attend. So because you'll be losing because your this thing is 10 marks for each question as far as theory is concerned. So if you do not attend one question, 10 marks is gone. So you should attend, even if you don't know anything, write something, because then the examiner will have some privilege of giving some marks, so that will be added to your total marks. If you have not attended, he has to give you 0. I hope you have understood, isn't it? That's why I keep telling all my students not to, miss any question. All 10 questions you have to attempt. Even though you may not know much about the question regarding the answer, but still write down something. Okay, so any doubts? None of the students are putting anything in the chat box. The chat box is absolutely empty. That means everybody have understood about the reversal agents, neostigmine. And we also discussed about the side effects of neostigmine. By itself, it can produce, weakness of the neuromuscular junction and weakness of the muscles. That's why if patient is completely reversed, if you are using a quantitative monitoring and you think that the train of 4 is 1, don't give neostigmine unnecessarily. But there was a school of saying that even if you think that the patient is completely reversed, even if you give neostigmine just like that, because we know that 70% of the receptors could still be blocked by non-depolarizers. That is what yesterday also I was discussing, 30% of the receptors, if they are free from neuromuscular blocking agents, the patients will have complete power. And your neuromuscular monitor cannot detect. Trainer 4 ratio will be 1. If just 30% of the receptors are free from neuromuscular blocking agents, that is the margin of safety in the neuromuscular junction. Still, there is a possibility of 70% of the receptors may be blocked. That's what I was telling you, that if the patient goes to the postoperative ward and, kanamycin, amikacin, or any gentamicin, or any of these aminoglycosides are given, so there is a possibility that the patient may develop recurization because some more, some decrease in the acetylcholine level. So there will be a preponderance of the effect of non-depolarizers at the neuromuscular junction. There can be recurization or residual neuromuscular palsy can occur. So that is why people were telling that even if you get trainer 4 of 1, you still give neostigmine. Because anyway, the remaining receptors which are blocked by non-depolarizers will be reversed by the additional release of acetylcholine by neostigmine. But what has been found is when you give neostigmine unnecessarily, there is no necessity of giving neostigmine, isn't it? Because the patient has got full power. So unnecessarily, if you give neostigmine, that is a repeat dose of neostigmine, there is always a possibility of neostigmine by itself producing muscle weakness. I told you how it produces muscle weakness because any increased level of acetylcholine at the neuromuscular junction can produce now a sustained effect there, like succinylcholine. So it associates with the receptors, dissociates and reassociates because it is not getting destroyed by acetylcholinesterase. That is what occurs with succinylcholine. So a sustained depolarization can occur, and sustained depolarization can produce a depolarization type of block, which can even lead to a phase 2 block. So unnecessarily, that is the advantage of using a quantitative monitor. If you have a quantitative monitor and if QOF is 1, ratio is 1, you don't have to give reversal with neostigmine. And another question I did not ask you yesterday is, okay, you are given neostigmine full dose, 0.05 milligram per kg body weight is the full dose of neostigmine. You have given, you are not using quantitative monitor, and you thought that the patient has some amount of recovery. He was slightly moving. The surgery is over. The surgeon has already gone. And, people were pressurizing why a patient is not getting up. You thought, let me give neostigmine, and you give neostigmine. And we know that if you give neostigmine when the patient has got, slightly deeper type of block, whether it is even, it need not be intense block or deep block, even if it is a moderate block. And I told you, if there are only 2 twitches with the trainer 4, you should not give neostigmine because it will take a long time to reverse, or sometimes it may not be able to reverse. Ideally, it should be given when trainer 4 ratio is 0.4 and above. So suppose you think that, okay, slightly patient is moving, let me give. And you give 0.05 milligram per kg body weight of neostigmine, and patient is, slightly is moving more, but not completely come out. Can I use another 0.05 milligram per kg body weight of neostigmine? Can I give another second dose?
No, sir. It
Why?
again produces ceiling effect.
It has the
Yeah,
ceiling
very good.
effect.
So if first dose has not produced any effect, there is no point in giving second dose. Second dose will not produce. Yeah, so actually it may increase the amount of blockade there.
Okay.
Now again, by depolarizing type of block, it is like giving, already you have given non-depolarizers, and over that the patient has not come out, you are trying to give succinylcholine. Can you give succinylcholine in a patient who has not come out of non-depolarizers? You don't give. And it will be like that. So do not try to give a second dose. Just wait for the patient to come out. Invariably, the patient is going to come out because the molecules of non-depolarizers, they have to get dissociated from the receptors. They cannot remain there permanently because they're all intermediate acting drugs, what we are using. They get dissociated, enter the plasma, enter the liver or kidney, they get eliminated. So we'll have to wait for that. So don't try to give one more dose of neostigmine. Actually, it can produce more problems.
Okay.
By giving another dose of neostigmine, it can pronounce the muscarinic effects also, like intense bradycardia and release of all secretions, bronchoconstriction. All those problems can intensify if you give unnecessarily second dose. So don't try to give a second dose. That will be a disadvantage. That is a disadvantage actually with neostigmine. You cannot use the second dose. That you should always understand. And neostigmine, that is why the minimal dose of neostigmine should be used. If you think that the patient has almost come out, he is breathing well, he is even lifting the head, and then in that situation, you go for lesser dose of neostigmine. Though you are not monitoring the neuromuscular junction, but the patient has almost come out, he is even lifting his head. If you allow, you'll even pull out the endotracheal tube. If that is the situation, you just go for 20 mics per kg body weight of neostigmine. Don't go for full dose of 50 micrograms per kg body weight of neostigmine. So those things you should always understand. That will be enough, actually. Okay.
Okay.
So, again, that's a few extra things about neostigmine reversal. And again, coming to Sugammadex, we're discussing about Sugammadex. We just now discussed how the mechanism of action of Sugammadex and why it is named also Sugammadex, because it's a sugar containing.
Gamma cytotoxic.
Yeah, that is the reason why it was called as Sugammadex. And Eaton Baum was the person who introduced this. Accidentally, he discovered Sugammadex as a reversal agent, as a selective reversal agent for aminosteroids. So coming to its pharmacodynamics and pharmacokinetics. So what is the pharmacodynamics other than blocking the rocuronium? What are its effects on CNS, CVS, respiratory system, and then liver, kidney, everything? Pharmacodynamics, effects on various systems of the body.
Sorry.
What is its effect on CNS, CVS? Because this is another very important thing we should always know about, because we know about how neostigmine can produce all its side effects on respiratory system, on CVS, and all other things, isn't it? So like that, even postoperative nausea and vomiting. So how about Sugammadex? What are its pharmacodynamic effects?
Sorry.
Anybody in this thing discussion, the other participants, they can always put their answers in the chat box.
Sorry, it causes bradycardia.
No, I'm not asking the side effects.
Okay, sir.
Its effects, other effects.
Other.
Now, one thing you should realize, Sugammadex is absolutely benign. It doesn't have any effect on any systems of the body. It's a totally benign drug. It doesn't have any CNS effects, no respiratory effects, no cardiovascular effects. That is the reason why you have not read anything about its pharmacodynamics. So you got confused actually. So that's we try to confuse you in the examples. So you should always remember about these things. So don't try to, and once you know exactly, very clearly the subject, then you will not get confused. So it is absolutely benign and doesn't have any pharmacodynamic effects at all, other than binding to rocuronium or any of the aminosteroids. Okay, what are the pharmacokinetics of Sugammadex? How it gets metabolized, how it gets eliminated?
So it's excreted in urine,
renal excretion, okay.
excretion.
How about its metabolism?
No metabolite of Sugammadex is.
No, where does it get metabolized?
Metabolization.
Or is it 100% excreted through
It
kidney?
is Almost 100% is
Almost,
excreted in
in
urine
urine
only.
sir.
It is 100% excreted through kidneys.
Okay.
It does not metabolize in the liver at all. It is 100% excreted through kidneys, and majority of the drug will get excreted in 2 hours. And in 24 hours, more than 90% of the drug gets eliminated through urine.
Okay, sir.
Within 24 hours, more than 90% of the drug gets eliminated through the urine. So that whether, now you know this. And what about the combination of rocuronium and sugammadex? Suppose you give sugammadex to a patient just like that. So since it is absolutely benign, it will not produce any pharmacodynamic effects, and it gets excreted through the kidneys. By in 24 hours maximum, most of the drug gets eliminated. Now you are not going to give sugammadex unnecessarily. So you are going to give sugammadex only to reverse the effect of rocuronium. So when you have given rocuronium, now you have given sugammadex. What happens is, if you are given more molecules of sugammadex than rocuronium, then all the molecules of rocuronium gets bound to sugammadex.
Yes, sir.
There won't be any free rocuronium molecules at all, because the number of sugammadex molecules are higher than the rocuronium molecules. And sugammadex invariably is going to block all the rocuronium molecules. And it pulls all the rocuronium molecules from neuromuscular junction or anywhere in the tissues. It starts pulling because the concentration gradient is created, and it tries to block all the rocuronium. It won't leave any single molecule of rocuronium unbound in the plasma. Now, what happens to this rocuronium and sugammadex complex? Because that rocuronium, it is 75% metabolized in the liver and excreted through bile, and 25% excreted unchanged through the kidneys, rocuronium. Now, what happens to this complex? Sugammadex rocuronium complex. How it gets, does it require again liver? 75% of it is metabolized in the liver and 25% eliminated through kidneys, or 100% eliminated through kidneys? The complex I am asking about.
It requires biliary excretion. Not
A
sure,
little
sir.
amount of biliary excretion and
Again, guessing. When you answer, as examiners, whether you are guessing or whether you are very clear with your and
yes.
you just, try to throw a stone at a mango tree, you may get one mango hit, isn't it? That's what. So, but the complex is 100% excreted through kidneys.
Yes. Okay.
That's how, the rocuronium pharmacokinetics change when you use sugammadex. Otherwise, rocuronium alone, if you had left it alone without giving sugammadex, 75% would have been excreted through biliary excretion and 25% unchained through the kidneys. Now, once you give sugammadex, so rocuronium will not get, whatever the rocuronium that is there in the plasma, or everything is bound to sugammadex, and whole thing gets excreted through kidneys. So now you know that, now you know the complex, how it gets excreted, and also you know how sugammadex is excreted. For example, now you give, I'm just giving you an example. There are actually total molecules of rocuronium is only 50 in the blood, including tissues everywhere. And you have given 100 molecules of sugammadex. So that means 50 molecules of a complex will be there now, sugammadex with rocuronium, and 50 molecules of sugammadex alone will be there, isn't it? So all these, whether it is sugammadex or sugammadex with rocuronium, will be excreted through kidneys. Now you are clear, isn't it? So now rocuronium cannot be metabolized in the liver or excreted through biliary excretion at all, once you have given sugammadex. And whatever the rocuronium which was there, you had given rocuronium, you will give repeat doses of rocuronium many times, isn't it? And finally, at the end of surgery only, you will be reversing. So till then, whatever the rocuronium that comes to the plasma goes to the liver, 75% will be excreted through biliary excretion, and 25% will be excreted through kidneys. Till you give Sugammadex. Once you give Sugammadex, now the complex that is formed, now it changes the pharmacokinetics of rocuronium. Now, rocuronium does not require liver for its biliary excretion because it is now bound to Sugammadex and the complex will be excreted through kidneys. Now, one more thing is, what about this binding? How much deep is this binding, or how much strong is this binding of rocuronium with Sugammadex? How strong is the binding? Can it get separated?
No, sir, it forms a very tight, stable
How much stable?
percentage. Not sure.
Not percentage as such.
Okay.
Out of 25 million complexes, there is a possibility that one molecule may get separated.
Okay.
You can imagine 25 million means 250 lakhs or 2.5 crores complexes are there. One complex may dissociate. That means almost negligible. There won't be any dissociation at all of rocuronium with Sugammadex. Totally, it is a very tight complex and it will be excreted through kidneys. Now, once we know that it requires normal renal function for excretion of the Sugammadex and rocuronium complex. What happens in patients with renal disease? Or can I use Sugammadex in patients with kidney disorders?
No, sir, it is not recommended because the creatinine clearance, I mean, it's right.
If it's less than
Since it's 100% excreted through kidney.
No, but in all CKD means what? When GFR comes down to less than 60 ml per minute per 1.73 square meters of body surface area, for more than 3 months, you call it as a CKD, chronic kidney. So patient can have 50 ml of GFR or 40 ml of GFR. Anything less than 90, you call it as reduced. So, but end-stage renal disease is less than 15 ml of GFR. That you call it as end-stage renal disease, and patient cannot survive without dialysis. Now, let us say that a patient is there with 40 ml GFR, or another patient is there with 20 ml of GFR per minute. Can I use, Sugammadex in these patients? Ideal.
20 ml, avoid using
20
Sugammadex.
ml you avoid, 40 ml you give, is it?
No, sir, anything below 50,
What is
let's
the
have.
Now, what is the books say cutoff as far as GFR, that whether to use Sugammadex or you don't use Sugammadex? What is the GFR cutoff? So in between what I said,
40, 20, 30, sir.
30 ml. 30 ml is, the GFR, above which they say that you can still safely use Sugammadex for patients where you have given an amino steroid in patients with chronic kidney disease. But you avoid giving Sugammadex for patients with less than 30 ml because it will take a longer time for the complex to be excreted. Will there be any problem? Suppose, this is actually the advice that less than 30 ml patients with less than 30 ml of GFR, you don't use Sugammadex if to reverse, rocuronium. By chance, you have given in a patient less than 30 ml of GFR per minute. So will there be any problem? If the complex remains in the blood for a longer time, it may take even more than, say, 48 hours for the complex to be excreted through kidneys because there is a GFR is reduced. Will there be any problems? if
May-
this amount of complex,
Recuriorization.
pardon,
Risk of recuriorization.
no, there won't be any, it is not going to, that's what I told you, the association is very strong.
One second.
The dissociation will not occur between the two molecules. And you know, the complex also doesn't have any pharmacodynamic effects. Absolutely no pharmacodynamic effects, benign. So even otherwise also there may not be much problem even, but how you can, see that this complex is excreted out, what you may have to subject the patient for. So that you can remove this complex from the plasma.
Hemodialysis.
Hemodialysis, the patient may be subjected to high flux hemodialysis. Regular hemodialysis may not, take out the complex, but they say that you have to go for a special type of dialysis, which is called as high flux dialysis. So high flux dialysis will remove the complex. So that you should always keep it in mind to whether to give or not to give. That is one very important thing you should understand about. So, okay, now you know the pharmacodynamics and pharmacokinetics of Sucamadex. Now you tell me what are the advantages of Sucamadex over neostigmine reversal. What are the advantages of Sucamadex?
Complete reversal, so there will not be any undesirable side effects of neostigmine.
Right.
Like
No. Neostigmine you are not using, isn't it?
Yes.
Instead of using
not
neostigmine,
any residual blockage, sir.
yeah, one very important thing is there won't be any residual block. So we know that in certain patients, residual block can occur, and we were also talking about residual block yesterday. What percentage I told you that if you're not monitoring the patient with a quantitative monitor, what is the percentage of residual block?
70%.
Nearly 40 to 50%,
50%.
isn't it? 40 to 50% of the patients can have residual block in the postoperative period, and we know all the problems associated with residual block. Unnecessary patient can have, extended ICU admission or hospital admission, and all complications can occur. So, and it is very common in, obese patients and also very common in older age patients, residual neuromuscular palsy, because the obese patients and older age patients are highly sensitive, especially obese patients with OSA, obstructive sleep apnea. So highly sensitive for the neuromuscular blocking agents. So residual neuromuscular palsy is quite common in these patients. Plus in those patients with respiratory disease, again, like a patient with COPD, already is not able to breathe well. So you are adding neuromuscular blocking agents, and that itself can produce some amount of residual neuromuscular palsy in the postoperative period. And that can produce real problems for these patients with COPD. The other thing is when you're using a longer acting, drugs, like, for example, you have used pancuronium. Unfortunately, that is the only drug available with you and you wanted to use it. So again, there is high chance of residual neuromuscular block when you're using long-acting neuromuscular blocking agents. So that way, when you give Sucamadex, definitely you can avoid residual neuromuscular palsy. So that is one of the advantages. Okay, any other advantage?
It is
Even
faster than neostigmine.
Rapidly acting, definitely. That is another very good advantage. That what is how much time Sucamadex takes to reverse, and how much time neostigmine takes to reverse?
Sir, Sucamadex take 2 minutes
Yeah, less than 2 minutes
to reverse.
to reverse. And how about
It is about 7 to 10 minutes in neostigmine.
nearly 10 minutes to 15 minutes, because the peak effect is 10 to 15 minutes of neostigmine. So it may take a long time to reverse compared to Sucamadex. So early reversal is always an advantage with Sugammadex. Okay, one is no residual neuromuscular palsy. Second thing is faster reversal with Sugammadex. Okay, then.
So even
Clear-
reverse
Huh.
profound depth of block.
Profound depth of block.
It can reverse.
Yeah,
Sugammadex.
very good. Very good. Very good. So excellent. That is another very important aspect of Sugammadex, because just now I was telling you about neostigmine. If the patient has got an intense block or a deep block or even a moderate block, neostigmine may not be able to reverse. Whereas intense block or even deep block or even a moderate block, Sugammadex is going to reverse, because the method of reversal with Sugammadex is entirely different. It is going to, pull all the molecules of, rocuronium or vicuronium from the neuromuscular junction into the plasma, and then further binds them and make them inactive. So that is another very good advantage where deeper blocks can be reversed. So if you say that deeper blocks or intense block can be reversed, how you use it clinically as an advantage? Clinical application of this particular, advantage of
Patient
block
complete
and
rec-
deep block. Pardon?
Patient will have complete recovery.
No, complete recovery. Already we said residual neuromuscular block will not be there. So how you can apply this particular advantage of, the complete reversal even when the patient has intense block or complete block or deep block?
So during the last 10 minutes or something, we have given a neuromuscular blocking agent, and we can reverse immediately if it has this property.
No, when you usually give last dose?
Last dose for
40.
No,
for
no, you have given anesthesia for open abdominal surgeries.
Yes, sir.
yes, sir.
Now, what the surgeon wants you when he wants to close the peritoneum and rectus?
You want
You
complete
want complete
relaxation.
relaxation.
Yeah, he
so
wants you to give extra
relax-
relaxants, but you will be reluctant to give extra
Correct.
relaxants, isn't it?
Yes.
You know that another 10 minutes he is going to finish, but you have to wait for another 15-20 minutes to reverse extra, isn't it? Because you know that last dose, from the last dose to your reversal of neostigmine, giving neostigmine, it should take at least 25 to 30 minutes. That should be the ideal interval from the last dose. Now, with the advent of Sugammadex, you can even ask the surgeon, do you want relaxation?
Yes.
When he is trying to close, you can always ask, sir, do you want relaxation? I'm going to give extra relaxation. Absolutely no problem. You can give extra dose. And Sugammadex is always there, your friend, to help you to, clear the rocuronium molecules, isn't it? So that's a great advantage, isn't it? That way, even you can keep giving the muscle relaxants even till the end of surgery without any problem. And this is again very important. In already we had discussed this in laparoscopic surgeries. In laparoscopic surgeries, as I told you, that the surgeon requires a very compliant abdominal cavity or peritoneal cavity. Because you must have seen if the compliance of the abdominal cavity is less, especially in obese patients and all. So the pressure required to produce an increase in volume or space inside is much higher, isn't it? So because it all depends on the compliance. Compliance is nothing but volume change per unit pressure change. So the compliance is very high. With a small pressure, the volume can be increased very much. So that if you can produce very good abdominal muscular relaxation by giving an intense block, so the surgeon can use small amount of intra-abdominal pressure. He won't go for pressures beyond, say, 12 millimeters of mercury of intra-abdominal pressure, and he will have very good space, very good room to operate. Otherwise, he will be using even more than 15 millimeters of mercury of the pressures, and any increase in pressure of more than 15 millimeters can produce all the problems of pneumoperitoneum. It can compress the inferior cava, it can compress the aorta, it can push the lungs, the diaphragm much higher. The compliance of the lung decreases, the peak inspiratory pressures will increase, the CVP will increase, systemic vascular resistance will increase, cardiac output will come down, peripheral stasis of blood will increase, there is chances of DVT, deep venous thrombosis. You can imagine all sorts of problems can occur if there is increase in the intra-abdominal pressures during pneumoperitoneum. But the problem for you is, it is not like closing the abdomen, the surgeon will take about 10 to 15 minutes. Here, laparoscopic surgery, he will just, once the, whatever the cholecystectomy, for example, once he takes out the gallbladder, afterwards he takes only about 3 or 4 minutes just to put some sutures of small openings will be there of the holes he has created. So he just put 1 or 2 sutures and that's all. Another 5 minutes he's going to finish. But if you had given a complete reverse, complete muscle relaxant, so you'll have to wait for another, say, half an hour or 45 minutes to reverse. You all must have had this problem.
Yes.
So, but the advantage of having Sugamadex with you is you can produce a deep block or intense block till the end of surgery, so that the surgeon will be very happy and he need not have to use extra pressure to create more room in the the peritoneal cavity. So his surgery also will be faster, and all the problems associated with pneumoperitoneum are not there for the patient. And this is especially true in ASA class 1, you may not have any problems, much problems, but you can imagine in ASA class 3, class 4 patients, even pneumoperitoneum of more than 15 millimeters can produce a lot of problems in the physiology of the patient. So that way, it is a great advantage to have with you Sugamadex, so that you can give extra amount of relaxation till the end of surgery. So you need not have to worry at all to wait for giving a reversal agent. You can just, as the surgeon is putting the sutures, you just, give Sugamadex and the patient will be out of neuromuscular blocking agent. So this is another advantage, isn't it? One is, as you said, no residual neuromuscular palsy. That is a great advantage in many of the patients. Second thing is, you can reverse the intense block, and the advantage of that reversing intense block, one of the advantages is you can keep giving extra doses of neuromuscular blocking agents till the end of surgery, and you can reverse it. What are the other clinical applications of this? You can even reverse the intense block or a complete block where TOF is 0, your tetanic response is 0, PTC, post-tetanic count is 0. Nothing is there as far as the neuromuscular junction is concerned. Totally intense block. What is this application of reversing even intense block? When actually, do you produce intense block every day? Do you produce intense block every day for during your anesthesia when
Yes,
you're using neuromuscular blocking agents?
Intense block.
Yes, sir, we produce.
Yes, sir.
When do you produce intense block?
Induction time,
Huh?
during induction.
Induction.
During induction, why do you want intense block?
Vocal cords doing.
You are correct. You are correct. During induction and intubation,
Yes, sir.
you require intense block because you have to block the diaphragm, the adductor muscles of the larynx
Larynx.
for intubation. Unless you block them, you will not be able to intubate. That is why you require intense block during that time. That is the reason when you have a neuromuscular monitor, how do you know that there is an intense block? That trainer 4 will be 0. Tetanic response will be 0. PTC also will be 0. That is the time you just do a laryngoscopy, intubate, And that is always you produce an intense block. Okay, you have produced an intense block, but you're not able to intubate. You have gone in for cannot ventilate, cannot intubate situation. You're not able to ventilate with the mask, and you're not able to see anything. The laryngoscopy, grade 5, this Cormac-Lahane grading, grade 4, I mean, not grade 5 is not there. Grade 4 Cormac-Lahane, where you are not seeing any structure of the larynx.
We
Then,
can reverse the
okay,
patient.
then only alternative many times that was said is front of neck access.
Yes, sir.
You have to go for open the neck and then, by cricothyrotomy. But just imagine you have given rocuronium for that. What you can do now in such situation?
We can give Sugamadex.
You can give Sucamadex 2 minutes.
Reverse
It will reverse.
It will reverse, isn't it? Is it not an advantage?
Yes, sir.
So in such situation also, if you have, produced very good pre-oxygenation, and also you are having a para-oxygenation. What is para-oxygenation?
Apneic oxygenation.
Very good. What is this apneic oxygenation?
Means
Through nasopharyngeal airway, will connect
15 liters O2.
15
It
liters.
need not be nasopharyngeal airway, even it can be nasal prongs also.
Yes, sir.
If you are using about 15 liters of continuous oxygen, that is called as no desat, isn't it? What is no desat? So many questions.
Patient will not desaturate.
No
We don't have-
desat. NODESAT.
No descent. No descent.
Desaturation.
Capitals all.
Yes, sir.
Nasal oxygenation during effort of securing a tube.
Nasal.
Nasal oxygenation, NO,
Okay, sir.
during the effort of securing a tube.
Okay, sir.
That means laryngoscopy and intubation. No desat. No desat can be para-oxygenation is a short notes and 10 marks question. And no desat is one of the things which you always have to write down. Two things you'll have to write down. One is no desat. Another is thrive. You know thrive. What is
Transnasal,
humidified?
high low.
Humidified rapid insufflation of
Rapid insufflation of ventilation
ventilatory exchange.
exchange.
See, I have not read today to tell you about, I must have read long back, but I still is able to, tell you because, repeated readings, revising things, you can remember better. So now no desat and thrive or para-oxygenation methods. What is the difference between no desat and thrive? Though it is nothing to do with our today's discussion, but I just want to ask, no desat, you are giving 15 liters of oxygen or 10 liters or 15 liters of oxygen from your anesthesia machine itself. What do you mean by thrive? Transnasal humidified,
Already.
rapid insufflation,
No.
ventilatory exchange. What is this? How much of oxygen, how many liters of oxygen you will be giving with thrive? That to
Thrive?
humidified oxygen.
We don't know.
You can give up to 70 liters
Okay, sir.
of oxygen. It is heated and humidified. Heated and humidified. Up to 70 liters of oxygen you can continuously give through special, nasal prongs and a special equipment, thrive equipment is there. Isn't it? Do you have thrive in your OTs?
No, sir.
Yeah, thrive. You should have at least one machine so that you people as postgraduates will know what are the uses of tubeless anesthesia. You can provide tubeless anesthesia with thrive if you have thrive. You need not have to put a endotracheal tube. because there is a ventilatory exchange also is there. That means carbon dioxide is also coming out. Oxygen is going out, going in. That is what is VE, thrive. Ventilatory exchange is occurring. And also it produces some amount of PEEP. Every 10 liters will produce 1 centimeter of PEEP or CPAP. Now, so if you're using 70 liters, 7 centimeters of PEEP also will be there. So PEEP will maintain FRC. FRC will be good. So better oxygen exchange. So maintenance of better PaO2 with Thrive. So there are so many advantages with Thrive. So these are all para-oxygenation. Suppose if you are also using para-oxygenation, even if you have found difficulty, not able to ventilate, not able to intubate, in such situation, the saturation will not drop immediately. It will take some time, maybe about 10 minutes or 15 minutes. Till then, the patient will not develop hypoxia. So in such situation, you can also give Sugammadex, and 2 minutes or 3 minutes, the patient is, completely reversed. So there is an advantage, isn't it? That is an clinical application of reversing intense block with Sugammadex.
Okay.
And one more clinical application here. So for rapid sequence induction, what drug you would be using usually?
Succinylcholine.
Okay, now let us say that you don't want to use succinylcholine because succinylcholine has got a lot of complications. It has got its own complications. And there are a lot of contraindications for the use of succinylcholine. For example, a burns patient after 6th day or 7th day, he is posted for some surgery. You have to go for an emergency surgery. You have to go for a rapid sequence induction on intubation. So now you cannot use succinylcholine. So if you cannot use succinylcholine, can I use rocuronium?
Yes.
Yes, sir.
Yeah, that is another clinical application of this. You can safely go for use of rocuronium in such situation wherein there is a contraindication for succinylcholine. There is an absolute contraindication for succinylcholine. So you can just give higher dose of rocuronium. We'll come to that. What is the dose you have to give for? Okay, anyway, let me ask you here. What is the dose of rocuronium you'll be giving for rapid sequence intubation, induction and intubation?
0.1,
Rocuronium.
0.2, sir.
What is the intubating dose of rocuronium? Good thing that I asked you this. Because you people are not involved with muscle relaxants, but you should know.
0.3 to 0.6 mg per kg.
0.3 is the ED95.
Okay.
Twice the ED95 is the intubating dose. So for normal intubation with rocuronium, it is 0.6 milligram per kg body weight. So what about rapid sequence induction and intubation?
1 to 1.2 mg we can.
Up to 1.2 milligrams, you have to use. Rocuronium, you have to give 0.9 to 1.2 milligram per kg body weight. So that is almost 4 times the ED95, or even that's how succinylcholine also you give 4 to 5 times the ED95, because the ED95 of succinylcholine is 0.3, same 0.3 milligrams, but you give 1 to 1.5 milligram per kg body weight. For normal intubation, you give 1 milligram per kg body weight. For rapid sequence intubation, succinylcholine, you go for 1.5 milligram per kg body weight. Like that, rocuronium, also for normal intubation, you use twice the ED95 of 0.6. For rapid sequence, you go for 3 to 4 times the ED95, that is 0.9 to 1.2 milligram per kg body weight. Even if you have given 1.2 milligram per kg body weight of rocuronium and you are not able to see anything there, it's an absolute difficult laryngoscopy and intubation. And you can reverse the effect of this high dose of rocuronium within 2 minutes. That is another clinical application of using Sugammadex. One more thing, especially in pregnant patients, if you want to give GA. Many times these pregnant patients, when they require GA is when they have eclampsia, preeclampsia, all those things. When they have bleeding, isn't it? Where you cannot give your, one of the absolute contraindications for spinal or epidural is if the patient is bleeding, a bleeding diathesis is there, bleeding tendency is there. For example, HELP syndrome. isn't it? HELP syndrome in preeclampsia. So you cannot use, central urine axial block, or the patient is unconscious because of eclampsia. In unconscious patients, definitely will not go for a central urine axial block. So we have to go for, GA only. Let us say that the patient is on a continuous infusion of magnesium. Then you'll think twice before giving succinylcholine, because the effect of succinylcholine also will be prolonged by your magnesium. Plus, the neuromuscular blockade will be very intense and gets prolonged with magnesium, and the patient is on magnesium when you are using. In all such situation, I think Sugammadex you can definitely use to first, rocuronium can be used for rapid sequence induction and intubation in pregnant women. And, you can definitely use Sugammadex because all pregnant women are considered to have a difficult airway. And that too with a patient with preeclampsia, with so much of swelling of the tongue, so much of edema of the face, short neck. And, such are the patients who likely to go for cannot ventilate, cannot oxygenate, cannot intubate situations. That preeclamptic patients. That's why in such patients, you use your ultrasound probe to identify where is the cricothyroid membrane. You already mark the cricothyroid membrane because you may have to go in for a front of neck access in such situations, isn't it? So that is an application of ultrasound in airway management of preeclamptic women, obese preeclamptic women, where you will not be able to identify the membrane, cricothyroid membrane. So in all such situation, you can still use rocuronium as the dose for rapid sequence induction, and you can rapidly reverse using Sugammadex. That is another very good clinical application of this particular advantage of Sugammadex. Okay, where else you can use as an advantage of Sugammadex? What are the other advantages of Sugammadex? I'll give you a clue. Okay, a patient is for ambulatory surgery. How you can use your Sugammadex in patients with ambulatory surgery? Daycare surgery, and that is today only some conference or CME is going on daycare surgery. Okay, daycare surgery patient, you have to, how Sugammadex is going to help you. What are the problems of using muscle relaxants in daycare surgeries? Okay, for example, now you want to use succinylcholine in a daycare surgery patient. What problems you can expect with succinylcholine when you use for daycare surgeries? What is the problem with succinylcholine? If you make the patient ambulant fast and then send him home, what one complication of or side effect of succinylcholine will make you not to use succinylcholine for daycare surgeries, but to avoid? That too in a male patient with good muscles.
Hyperkalemia. Hyperkalemia.
Hyperkalemia is only in patients with upper motor neuron palsy, lower motor neuron palsy, burns, all those things, myopathies, dystrophies, muscular dystrophies. Those are the patients who develop hyperkalemia. Not every patient. Let us say ASA class 1, because most of the time daycare surgeries are taken for ASA class 1 patients. Of course, we are also doing daycare surgeries in ASA class 2 and class 3 also nowadays, but majority of them will be class 1. They come in the morning and you subject them for anesthesia, surgery is done, and say you keep them for 2 or 3 hours in the post anesthesia care unit and then send them home if they satisfy all the criteria for sending them home, isn't it? What problem of succinylcholine? Nobody is using a chat box also. No, it is myalgia. Succinylcholine produces intense myalgia, especially in male patients with good muscles. because of the fasciculations, because of breaking down of muscle spindles. So there can be an intense myalgia, and post-operatively the patients can have a lot of myalgia. And you don't want the patients with the daycare surgeries to have this, isn't it? If the patient is not a daycare surgery, and he's an inpatient, then you will be using very good post-op analgesias, and that will take care of succinylcholine induced myalgia. But daycare surgeries, you cannot give too much of analgesics also in the post-operative period. They have their own side effects, like gastritis, if you are using non-steroidal anti-inflammatory drugs. And invariably, you just try to give some paracetamol, some drugs like that for patients with in the post-operative period for daycare patients. So in such situations, but you will be reluctant to use your non-depolarizing muscle relaxants because you don't want any residual neuromuscular palsy in these patients.
Yes, sir.
Just imagine the patient has been admitted for a daycare surgery and the patient has developed a residual neuromuscular palsy. How can you cannot sit at home.
Yes, sir.
So it requires more hospitalization, isn't it? That is, for example, now you don't want to use succinylcholine. Now you can use rocuronium or vecuronium. You reverse it with sugammadex. And you know that residual neuromuscular palsy is incidence is very low with sugammadex. So is it not an advantage for using sugammadex in daycare surgeries?
It is an advantage.
It's a very good advantage. Okay. What other advantages of using sugammadex? We know that the anticholinergics have got a lot of side effects,
Yes, sir. This has
including residual neuromuscular palsy, plus they can also have their own effect on the cardiovascular system, respiratory system, gastrointestinal system, all those things yesterday we discussed. So by using sugammadex, can you avoid all these problems associated with anticholinergics?
Yes, sir.
Isn't it? You need not have to use neostigmine when you have sugammadex. So once you give sugammadex, all these side effects associated with anticholinergics you can totally avoid. So is it not an advantage? It's a it's a very good advantage, isn't
Yes,
it?
sir.
What other advantages with that?
Sir, can use an elderly with
Elderly, as already I said that elderly needs an advantage, especially because residual neuromuscular palsy is very high. Already we have discussed that. Where else this can be an advantage? In which other patients?
No.
Can we use in pediatrics, sir?
Yeah, that's a good question you asked. So you should answer. I should have asked that question and you should have answered. So now you have to answer. Can we use sugammadex in pediatric patients?
What we read is more than age of 2 we can use.
Not like that.
Correct. Because it has not been studied in smaller aged children, especially less than 2 years. It has not been studied. So that is the reason caution is that you use sugammadex only for children above the age of 2 years.
Okay.
Okay, so any other advantage of using sugammadex? Any in other patients where you will be very, very cautious in using neuromuscular blocking agents, whether it is succinylcholine or whether it is non-depolarizing muscle relaxants, in which patients there can be, lot of, the pharmacokinetics and pharmacodynamics can be, a lot of changes can be there of these neuromuscular blocking agents.
Burns patients.
Not burns, you can safely use non-depolarizers. Of course, burns patients, non-depolarizers, there will be resistance. Depolarizers you cannot use. There will be resistance for non-depolarizers. You require higher dose of non-depolarizers. Why there will be resistance for non-depolarizers in burns patients? Because in burns patient, there is an upregulation of receptors.
Okay.
Yeah, more. That is the reason why you don't use succinylcholineals, because there are too many receptors, and the efflux of potassium will be very high by opening of these too many receptors. That is the reason why you avoid succinylcholine. But since too many receptors are there, more molecules of non-depolarizer are required to block these, because there is an upregulation of receptors in the neuromuscular junction. So that is the reason there is a resistance for the non-depolarizers. You require a higher dose of non-depolarizers in such situation. But still, as long as you use higher dose, no problem. But in which kind of patients, we're extremely careful. We were, when we were talking about hydrophonium, we discussed about this.
Myasthenia gravis.
In patients with
Crisis.
myasthenia gravis, myopathies,
Muscular
Right,
dystrophies. Yes,
yeah,
sir.
muscular dystrophies, where succinylcholine is absolutely, especially in muscular dystrophies and myopathies, succinylcholine is absolutely contraindicated. Why it's contraindicated in muscular dystrophies and myopathies? What it can produce?
It produce hyperkalemia.
Why it produces hyperkalemia?
More
Sodium
efflux.
influx and potassium.
No. There is no upregulation of receptors there in myopathies or in neuromuscular dystrophies, muscular dystrophies. There can be rhabdomyolysis. The
Okay, sir.
problem there is intense breakdown of muscle fibers can occur. When the patient has muscular dystrophy or myopathies, when you use succinylcholine, and there is intense destruction of these muscle fibers, means all the potassium inside will come into the extracellular compartment, sudden hyperkalemia, and the patient can get arrested. So that's why there is an absolute contraindication for the use of succinylcholine, but you still can use non-depolarizers, but these patients are highly sensitive for non-depolarizers. Even a small dose can produce intense blockade in these patients, and residual neuromuscular palsy is very high. And in all those such patients, definitely you can safely use non-depolarizing muscle relaxants, provided you are using aminosteroids and you are not using atracurium or cisatracurium. You can safely reverse the effects without producing any residual neuromuscular palsy. Now, these are all the advantages of Sugammadex. Okay, now any advantage of when you compare neostigmine with or conventional the reversal agents like anticholinesterases like neostigmine with Sugammadex, is there any advantage of Sugammadex, neostigmine over Sugammadex?
No need for anticholinergic.
No, neostigmine. No.
Neostigmine always require anticholinergic.
So
That may be a
Sugammadex,
disadvantage actually, but I'm asking you advantages of
Neostigmine over.
neostigmine over Sugammadex. Is there any advantage of Sugammadex, neostigmine over Sugammadex? Can neostigmine reverse all non-depolarizing muscle relaxants?
right? Yes, sir.
Isn't it?
Yes, sir.
Yes, sir.
Sugammadex.
You have used atracurium, whether you have used cisatracurium, whether you have used pancuronium, neostigmine you can use.
Yes, sir.
But what about Sugammadex?
Aminosteroid.
Only aminosteroids.
Only aminosteroids. Suppose you have used atracurium and if you want to use Sugammadex, it is of no use.
Yes, sir.
That is one advantage of neostigmine over Sugammadex. What is the other advantage? How many times you people have used Sugammadex? I just want to ask.
5-6 times.
Why you are not using routinely Sugammadex?
Cost effective.
Isn't it? One advantage of neostigmine is very cheap compared to Sugammadex, which is very costly. Second
Yes.
advantage is, if you want to use Sugammadex, will it be available with you on your machine desktop?
No, sir.
But neostigmine will be available
Always.
always, isn't it? So it is not easily available. One is availability. Neostigmine is easily available. Another advantage of neostigmine, it is very cheap compared to Sugammadex, isn't it? And third advantage is you can use neostigmine for all kinds of blocks of non-depolarizing muscle relaxants when compared to Sugammadex, isn't it? So these are some of the advantages of neostigminoids over Sugammadex, isn't it? Now, you know the advantages of conventional antagonists, reversal agents, and also you know about the many advantages of Sugammadex just now we discussed. Now, when you have Sugammadex, then can we avoid using benzyl isoquinoline group of drugs? Why do you want benzyl isoquinoline group of drugs? You don't use at all. You don't buy at all. Can I avoid totally use of benzyl isoquinoline group of drugs?
One, it is intermediate acting, sir. So,
No. Your vecuronium, rocuronium also intermediate acting.
sir, cisatracurium undergoes Hoffman elimination. So
let it undergo Hoffman's elimination. So what? When you have Sugammadex, you give any amount of rocuronium, any amount of vecuronium, you can reverse, no problem. Why do you want to have, that is why, in South Korea, they have only rocuronium. They don't have even succinylcholine. It's only in South Korea.
No.
When I was reading one of the articles, I found this. So can you avoid buying also cisatracurium, atracurium? Why do you want to have these drugs? Okay, I'll give you an example.
yes, renal.
Okay. Tell me if you have any.
In case of renal and liver disease, we can avoid vecuronium and go for cisatracurium.
In case of renal or liver disease, you can still use Sugammadex is fine.
But renal disease, we cannot use
Renal disease, yes.
because 100%
Usually-
excretion through renal. So
Yeah, because we just discussed about the pharmacokinetics of Sugammadex, because usually it is advised not to use Sugammadex in patients with GFR of less than 30 ml per minute, isn't it? So suppose you have a end-stage renal disease patient, you can definitely avoid using rocuronium, and you may require to use tracurium or cisatracurium, and you require to have it. You cannot say that I don't want atracurium or cisatracurium because it will be required. Can I use rocuronium in a patient posted for renal transplant surgery and use Sugammadex? Patient posted for renal transplant surgery, transplant has been done, and good amount of urine is there. And initially, because all these patients with end-stage liver disease, they are supposed to have a full stomach. And in such patients, you have to go for a rapid sequence induction. Let us say that unfortunately, the patient has slightly higher potassium levels around 5. And usually when the potassium level is 5 and above, 5.5, usually you don't use succinylcholine. But you wanted to avoid succinylcholine, can I use rocuronium 1.2 milligram per kg body weight? Anyway, the patient is going in for renal transplant surgery and kidney will be there and it will start secreting, it will start functioning. Can I use rocuronium in such situations?
Yes.
You can use, because what will be the GFR once renal transplant has been done? What will be the GFR for the patient? How much it will get increased?
It will improve, sir.
But we don't
No,
know
it
how.
will improve.
100%,
No,
100%.
immediately you see that urine output will start,
Yes, sir.
isn't it? So how much? For example, now another patient who has had a renal transplant comes to you. What may be his probable GFR?
More than 60, sir.
It will be more than 30 ml minimum.
Oh, yes.
Minimum more than 30 ml. Again, it all depends on type of kidney that is transplanted, whether it's a deceased kidney donor or whether it is a live kidney donor or whatever it may be. There are many types, isn't it? Even you can go for renal transplant with extended kidney donors also, like patients with more than 60 years. They are called as ECD donors, that is extended criteria for kidney donation. So anyway, usually it will be more than 30 ml. And once you anticipate that it can be more than 30 ml, definitely you can use rocuronium and you can use Sigmadex in such patients, isn't it? So you can safely use. That is not a contraindication, but usually we don't use rocuronium. We usually go for tracurium or cisatracurium or succinylcholine, because majority of these patients, they would have undergone a dialysis within around 6 hours before they are brought for renal transplant surgery, isn't it? Even if it is an emergency renal transplant surgery also, they will undergo, and invariably their potassium levels will be normal, and you can safely give succinylcholine, and you don't require to use rocuronium. Otherwise, can you use atracurium or cisatracurium for rapid sequence induction and intubation?
No, sir.
Why you don't use? Why
Because
you cannot use?
intermediate acting, sir. Not onset of action is
Very good. The onset of action is delayed. With cisatracurium, it is more than 4 minutes. With atracurium, it is more than 3 minutes. Even if you give higher dose also. Higher dose you don't want to give because release of histamine. So that is why you don't use atracurium or cisatracurium for rapid sequence induction intubation. You always use either succinylcholine or now rocuronium, because the use of or introduction of Sigmadex, that has helped. So that is one reason why you still require benzyl isoquinoline group of drugs. Where else they are always required? Benzyl isoquinoline group of drugs.
Short duration.
Pardon?
short duration surgeries and renal disease
Pediatric-
patient. Pediatric also we can use.
Yeah, pediatrics, very good. So less than 2 years, you cannot use.
Use
But you can
rocuronium,
still
that-
use. Have you not used vecuronium in pediatrics?
Yes, sir, we are using,
You
but
can use the neostigmine. There is no contraindication.
no.
You can always reverse with neostigmine. So there is no contraindication for using aminosteroids in pediatrics. But usually we go for atracurium or cisatracurium, but there is no contraindication as such. I'll give you a clue. Okay. Now you had used rocuronium for the patient and surgery is over. So you have given Sigmadex and reverse the patient with Sigmadex. Okay, after about half an hour, the surgeon wants to re-explore. You have to provide again general endotracheal anesthesia. Now, what drug you would like to use?
We cannot give an aminosteroid again, sir. We can go for
Yeah, because why you cannot use aminosteroid?
there is still Sigmadex in the plasma.
Very good. So there will be still a lot of molecules of Sigmadex, because Sigmadex will be using much higher than the molecules of rocuronium, isn't it? And we know that Sugammadex takes minimum 2 hours
2 hours.
to be excreted, but majority of it takes 24 hours,
Yes, sir.
isn't it? So in such situation, what drug you have to use? You have to use, if at all, atracurium or cisatracurium, you can intubate the patient and manage, isn't it? So that's how you definitely, there is a role for the benzyl isoquinoline group of drugs like atracurium or cisatracurium, even though we have Sugammadex. So this you should always know about.
Okay, sir.
So the other important thing is, have they used Sugammadex for those patients, rocuronium for those patients, again, who are brought for surgery after Sugammadex reversal? Is there any case reports? Now, what will happen now? If you again want to use rocuronium only. Like, for example, let us say you are in South Korea where you don't have a drug. You have to use rocuronium only for even those patients. Now you go for 1.2 milligram per kg body weight of rocuronium because they do require higher dose.
Higher dose.
That is what, even after Sugammadex has been given full dose 2 milligram per kg body weight or 4 milligram per kg body weight, and the patient has come back for, second surgery within, say, 1 or 2 hours, and they have given, after 2 hours, they have given rocuronium, but they had to use higher dose. And second thing is, it has taken slightly longer time to act. Normally, we know once you give 1.2 milligram per kg body weight of rocuronium, it takes just 60 seconds or even less than 60 seconds to produce excellent intubating conditions. But here it will take slightly long, maybe 1.5 to 2 minutes. It may take once you have already reversed the patient with Sugammadex. This is always there. So in such patients, can I use succinylcholine for intubation? You have given Sugammadex for reversal. Patient is brought within, say, 1 or 2 hours again. I want to intubate. Should I have to use only atracurium or cisatracurium, or I can also use succinylcholine?
We can use
succinylcholine.
Definitely, you can use succinylcholine. That is the reason why you want succinylcholine always, isn't it? You cannot do away with succinylcholine. You cannot say, why do I want to use succinylcholine? Now I have rocuronium. I can use 1.2 milligram per kg body weight of rocuronium to intubate. Rapid sequence induction intubation also I can use rocuronium. I can do away with succinylcholine. No. You can use succinylcholine for, again, reintubation. One. And where else succinylcholine may be required? Usually. Where else you require to use succinylcholine?
RSI.
No, RSI is over. Just now we said for even regular intubation also you'll be using. Otherwise, definite indication for succinylcholine other than rapid sequence induction and intubation.
Obese patient pregnancy.
No, there rocuronium you can use
Exploration of surgery.
because Sugammadex is there. You can definitely avoid succinylcholine. But where else? Laryngospasm.
Yes.
In laryngospasm, especially laryngospasm can be partial or complete. If it is a partial, you can even, ventilate the patient with oxygen with some amount of PEEP. And also you can give propofol or midazolam. Usually, it gets corrected. But if it is a complete one where absolutely closure of the vocal cords plus closure of even the laryngeal inlet, including the false vocal cords, the vestibular folds, that is called as a complete laryngospasm, where nothing can enter, not a single drop of oxygen can enter. And rapidly the patient will be progressing for severe desaturation. In such situation, ideal would be to give succinylcholine, and the dose required is very less, even just 0.1 milligram per kg body weight of succinylcholine is enough. to break this reflex laryngospasm. So that is the another reason why you always have to have succinylcholine with you. So this is the second advantage of, and where else you use succinylcholine as the drug of choice? Say in psychiatric patients,
ECT.
ECT, isn't it? Again, you require, because succinylcholine is very short acting. So there also you can, why unnecessarily use rocuronium? You can still use rocuronium because you have Sugammadex. But just imagine the cost. You are using costly rocuronium, plus you are using much costlier Sugammadex just for a patient posted for ECT. Still, the drug of choice in such situations can be succinylcholine, isn't it? So these are all the situations wherein you can still use succinylcholine only, and you need not have to use Sugammadex. Okay, can I use Sugammadex in liver disease patients? Can I
Yes.
use rocuronium and Sugammadex?
Yes,
Yes,
sir.
sir. Can be used.
Why you say that it can be used?
There's no liver
No
metabolism.
liver
Yeah,
metabolism.
because it does not require liver to be metabolized, and the rocuronium pharmacokinetics also will change. It does not require liver for its metabolism once you are using Sugammadex. That is what I said. The complex will have to, have the kidney for its, excretion, isn't it? So that way, you can still use in patients with liver disease. It is not contraindicated. You can still use rocuronium and you can reverse the patient with Sugammadex. Okay. Now coming to the dose of Sugammadex. What is the dose of Sugammadex? For example, now we always say that Sugammadex can be given in patients whom have used now 1.2 milligram per kg body weight of rocuronium, and I'm not able to intubate, I'm not able to visualize anything. I told you that you can use Sugammadex to rapid reversal of rocuronium, one situation. The second situation is, you can still keep on giving rocuronium till the end of surgery, and when probably the patient may still have intense block or deep block, or even a moderate block, there you have to use Sugammadex, and the dose will be different. Or when the patient has, already the train of 4 count is 2 and above, moderate block is there, or the minimal block or shallow block is there, you're using a monitor. So how much Sugammadex is required? So these are 3 clinical situations. The dose varies of Sugammadex. So, okay, let us say that first thing is, in a rocuronium, you have given 1.2 milligrams, you are not able to intubate. So you want to rapidly reverse. What is the dose that is advocated? So many molecules of rocuronium is there now in the blood as well as in the neuromuscular junction.
16 mg per kg.
Yeah, that's very good. So you require very high dose of Sugammadex. You require 16 milligram per kg body weight of Sugammadex. Okay, that is the dose for reversal of, then you had given high dose of rocuronium. Okay, second is the patient has a deep block or an intense block. There is only 1 or 2 post-tetanic count is there. PTC count is 1 or 2. Tetanic response is 0. Train of 4 is 0. Train of 4 count is 0. That is called as a deep block.
Yes.
If the dose you require to give.
We can give 4 mg per kg for.
And then the requirement is 4 milligram per kg body. Isn't it? So if the patient has got train of 4 of 2 count is there, PTC 2 count or 3 count is there, it is a moderate block. You can still reverse the patient with moderate block also with Sugammadex. What is the dose you require to give?
2
2
mg
mg
per
per
kg.
kg.
2 milligram. So this you should know. 2, 4, 16 or 16, 4, 2.
Okay.
So this is the dose usually you require to reverse. Suppose if the patient has got 0.4 of train of 4 ratio, can you still reduce Sugammadex?
Point. Okay.
You have a quantitative monitor is there. That's how, because of availability of quantitative monitor only, you now know that it is trainer 4 ratio is 0.4 or 0.6. But you have to reverse. And you're not using anticonvulsant stresses, you want to use Sugammadex.
So we can reduce the dose.
Yeah, how much you can reduce?
So we can give in the range of 0.1 mg per kg to 8 mg per kg.
No, that is too low. You can, instead of 2 milligram, you go for 1 milligram.
1 mg.
Milligram.
And anyway, you have the monitor is there. You give 1 milligram per kg body weight of Sugammadex and see what happens to the trainer 4 ratio. If the trainer 4 ratio becomes 1, you don't have to repeat. Suppose if the trainer 4 ratio has come up to 0.8, can I repeat 1 more milligram per kg body weight of Sugammadex now?
Yes.
No, because if it was neostigmine, I told you there is no point in repeating
Giving-
that, because
Yes, sir.
the healing effect is there with neostigmine. But what about Sugammadex? Now, it
We
was
can-
0.4. I gave Sugammadex, I wanted to reduce the dose. Unnecessarily, why should I use higher dose? I've given 1 milligram per kg body weight. So, but I found that the trainer 4 ratio is now 0.8. It is not 1 or 0.9. Can I repeat 1 more milligram per kg body weight or 0.5 milligram per kg body weight of Sugammadex?
Yes, sir, we can
Can
repeat.
give 1 mg per.
Can repeat the dose of Sugammadex. That is an advantage. That is an advantage with Sugammadex. Okay, now another situation is there where you have reversed with neostigmine. But the trainer 4 ratio is 0.6. And I told you that there is no point in giving a repeat dose of neostigmine. Now, can I use Sugammadex now? It was rocuronium, aminosteroid, and you had given full dose of 0.05 milligram per kg body weight of neostigmine. You have got a quantitative monitor, and the monitor is showing trainer 4 ratio being 0.6. That means the residual neuromuscular palsy is there. You cannot send the patient to the post-operative care unit, isn't it?
Yes.
You have to now see that the patient is completely reversed. Now, in such situation, after neostigmine, can I use Sugammadex? Now, I'm trying to tell you all the situations wherein how you can use Sugammadex.
We can give only.
Yeah, in such situation, you just give 1 milligram per kg body weight. Just now what we discussed. You are looking at the trainer 4 and then you are giving. It is not whether you have already used neostigmine or not, that is immaterial. Now the trainer 4 ratio is 0.6 and you give Sugammadex. Maybe you can try with say 1 milligram per kg body weight and see what happens to the trainer 4. If the trainer 4 becomes 1 or 0.9, you can definitely send the patient to the post-anesthesia care unit. Can shift the patient. So that is also a situation where Sugammadex helps when neostigmine cannot help. Where you cannot give a repeat dose of neostigmine, but still you can give Sugammadex. Isn't it? So these are the different doses of Sugammadex you can give, provided you are monitoring the patient with a trainer 4 monitor. But because we know that Sugammadex is going to reverse all kinds of block. Let us say that even if it is an intense block, you give 4 milligram per kg body weight, patient will be reversed. Isn't it? Otherwise, if it is a moderate block, you give 2 milligram per kg body weight of Sugammadex, you can reverse. Then why do you want to monitor the patient with using a neuromuscular monitor? Is there any use of monitoring when you know that you have Sugammadex and you can reverse? You need not have to use a monitor then. Why a monitor is required? Additional cost of say 4 lakhs or 5 lakhs for the monitor.
If dosage of drug is adequate or not, we can see if monitor is there.
Very good. So intraoperatively, I told you there are many situations wherein you know that you don't want any movement. Is you require to have an intense or deep block, isn't it? So in all such surgeries, unless you are monitoring, you don't know how much of the drug you have to repeat or when you have to repeat. Your rocuronium, when you have to repeat. So in all such situations, you definitely require a neuromuscular monitor. Or suppose you are not using rocuronium, you are using atracurium. You require a monitor so that you have to give neostigmine only when the 3:4 ratio is about 0.4. Till then, you cannot, you don't usually use neostigmine, isn't it? So that's how you cannot avoid a monitor. A monitor is essential and you have to use the monitor. Okay. So the other important thing is about the cost of Sugammadex. What is the cost of Sugammadex?
800, 600 to 800.
800.
No, what is the, no, which company is, giving you Sugammadex? What is the trade name of that, because you require to know that also.
The company we don't know, sir, but the trade name was reverse.
No, very good. At least you know the trade name of River Sea because it is neon people are, they
Yes,
have
sir.
introduced a much cheaper Sugammadex. Otherwise, it was available Sugammadex in India before also, maybe about 4-5 years since 4-5 years it is available, but each vial of Sugammadex was 3,500 rupees. Now, with this particular introduction of by neon people, say for the past say 2.5 years, now it is 750 rupees, 760 rupees to be exactly, to a vial of Sugammadex. So that the cost effectiveness is there. It is not too costly, and because the advantages are too many, because you can avoid residual neuromuscular palsy. That is the most important advantage, isn't it? So each vial of Sugammadex contains how many milligrams, how many ml?
So 200 milligrams in
In 1
One-
1 ml.
no 2 ml.
Totally it comes in 2 ml, sir.
Very good. 2 ml and total how much it will be there in?
200 mg,
200
sir.
mg. Total.
So 1 ml is
100 mg.
100 milligrams.
100 mg.
Yeah. So suppose the 50 kg patient is there, the surgery is over, and you require, usually majority of the times you require only 2 milligram per kg body weight. Unless the block is very intense or deep. As long as it is a moderate block, you require just 2 milligram per kg body weight. So because it is in a vial, definitely you can reuse it for other patients also, whatever that is the remaining, isn't it?
Yes, sir.
Just to have cost effectiveness. So a 50 kg patient requires how many milligrams?
100 milligrams if it's
100 milligrams. So how many ml you will be using?
1 ml.
1 ml.
1 ml. Cost of 1 ml?
450.
No.
350.
760 for
70 by 2, sir.
2 ml. So 1 ml will be, pardon?
380 rupees.
Yeah, 380 is it appears like Varshini is very good in maths. That's good. 380 rupees, isn't it? So suppose you are also monitoring and you want to give 1 milligram per kg body weight. Then you use in a 50 kg patient 50 milligrams.
2 milligram.
So how much of cost for the patient?
170.
Half of 380.
170.
19.
190.
Mona is not good in maths. Less than 200 milligrams, isn't it? That's how now you do have cost effectiveness of Sugammadex also is there. Definitely you can titrate the dose because you can give a repeat dose. But all these things provided you have neuromuscular monitor is available with you, a quantitative neuromuscular monitor. And how do you administer? Do you administer it very slowly or very rapidly? How much time you'll have to take to administer?
So slow administration.
Slow administration with the dilution.
Both of you are, no, it has to be administered rapidly within 10 seconds. So it has to be administered in just 10 seconds. Just like, your succinylcholine, adenosine, these are the two drugs which you require to administer very rapidly. Sugammadex is also one of the drugs you have to use very rapidly, you have to administer. Okay, so anyway, it doesn't have any pharmacodynamic effects. So no problem, isn't it? That is, and another dose requirement in obese patients. How much dose? How do you calculate the dose of Sugammadex?
Please.
Is it based on actual body weight? Is it based on ideal body weight? Is it based on appropriate body weight?
Ideal body weight.
Ideal body weight.
Is it ideal body weight or actual body weight or appropriate body weight?
Body weight,
Ideal
sir.
body weight.
Huh?
Ideal body weight.
No, it is actual body weight.
Okay.
That is another thing in obese patients we should always realize. It is based on the actual body weight and not on ideal body weight or appropriate body weight. So that is one of the drugs that you require to use based on actual body weight. Okay, so that is about Sugammadex and reversal agents. So any doubts? Because we don't have time to start opioids. So maybe another 7 or 8 minutes are left with.
Yes, sir.
Opioids will take next class.
Yes.
So any doubts for anybody? I think there are about 14 people are still there. About 20 plus were there and suddenly now they have come down to 14. Any doubts for you regarding Sugammadex?
So Sugammadex, does it have this hypersensitivity as adverse?
That also, yes, that is another thing which should have discussed. Good thing that side effects of Sugammadex. One is anaphylaxis.
Anaphylaxis? Yes.
Rarely it can produce anaphylaxis. And it depends on the dose you give. Higher the dose, chances of anaphylaxis is slightly on the higher side. But it is not very common. It's a total uncommon side effect, but anaphylaxis is one of the side effects of Sugammadex. You should always keep it in your mind. Okay, what is the other side effect Sugammadex can produce? Cardiovascular side effect. In very occasional patient, not in every patient.
Bradycardia, sir. Bradycardia is
Bradycardia and asystole. It has produced, these are the two complications. You can say they're not side effects, they are the complications of Sugammadex. Anaphylaxis and severe bradycardia, even sometimes leading to, asystole, but responds to atropine.
Okay, sir.
Whenever there is severe bradycardia, it will respond to atropine. And even anaphylaxis, definitely you can go for regular management of anaphylaxis using adrenaline and oxygenation and steroids. So, but you have to keep that in your mind, especially when you are using 16 milligram per kg body weight of Sugammadex. It may not occur when you are using 2 milligram per kg body weight of Sugammadex, higher dose. And as I told you, you have to give it rapidly, and that can induce, in very rare patients, anaphylaxis. These two are the complications of Sugammadex: anaphylaxis, severe bradycardia.
Okay,
Good
sir.
question that you asked about this. Okay. Anything else?
So one more thing, because of this anaphylaxis, can it be used in patients with bronchial asthma?
No, it is safe.
It's safe.
It's safe in all patients. It is a very, very rare complication. It is not a common complication, a very, very rare complication. Maybe 1 in 1 lakh patients may develop anaphylaxis. Because it is not a, because your vecuronium, rocuronium, succinylcholine are notorious to produce anaphylaxis.
Yes, sir.
Are we not using rocuronium, succinylcholine and all in bronchial asthma patients?
Yes, sir.
They're using. Like that, Sugammadex you can definitely use. There is no contraindication. No contraindication for Sugammadex except, GFR less than 30 ml per minute. And in pediatric age group, less than 2 years. These are the only two contraindications. And again, when you have used benzyl isoquinoline, there is no point in using Sugammadex. It will not repeat. One more reversal agent I was asking you, which can reverse both aminosteroids and benzyl isoquinoline. Yesterday I was telling you, it can reverse all the muscle relaxants. Whatever the muscle relaxant you use, all non-depolarizers. What is that?
L-cysteine.
Calabidione. Calabidione 2.
Yes, sir.
Calabidione.
Now it is still under experimentation, Calabidione 2. So it reverses both aminosteroids and benzyl isoquinoline group of drugs. So then you don't have to worry at all for using, whether you use atracurium, cisatracurium or rocuronium, vecuronium. You have Calabidione 2. It is very rapid and reverses everything. And you mentioned L-cysteine. L-cysteine is used for which particular drug?
Ganto.
Only for gantacuria. Only for gantacuria. L-cysteine produces cysteine adduction of gantacurium and it totally, without any effect. So the L-cysteine is used, so it produces cysteine adduction. That is how it produces or inactivates gantacurium. Because gantacurium is not being used, though it is an ultra short acting, benzyl isoquinoline group of drug. It is still under experimentation only since a long time. It has not, entered into commercial use, gantacurium. So that is why L-cysteine, we don't usually mention about it. But Calabidione 2, because it can be used for both for atracurium and rocuronium. So definitely you should know more about Calabidione once it is introduced. Probably in your time, you may be using Calabidione after say a few years. That is also a possibility. And you will be teaching your students about Calabidione, probably. Like I am teaching Sugammadex to you. Maybe it's not very far. Okay, anything to add? Okay, anyway, Mahal is there? Anyway, I just wanted to tell you next week, next Friday, Saturday, Thursday, Friday, Saturday, Sunday, I'll be in Wayanad for the Midcon is there, Kerala.
Okay, sir.
They have every 6 months PG sessions are there. It is called as a Midcon 2025. So I'll be, the first day I'll be talking about anesthesia machine for about 1.5 hours. So next day, chronic kidney disease case discussion and, intraoperative bronchospasm. So these 3 lectures I'll be giving. So all 3 days I'll be engaged. So next week we will not have the class.
Okay, sir.
Other next week we can have.
Okay, sir.
And that will be, second is Friday. So 9th, we will have on 9th next. So you can tell the next, batch of postgraduates who will be discussing with me about opioids.
Okay, sir.
Okay then.
Okay,
Okay,
sir.
sir.
Good night.
Thank you, sir.
A nice discussion.
Thank
Right. Right. Good night.
முடிஞ்சது